Good morning, ladies and gentlemen. Welcome to the next session. Good morning. Good morning. Good morning. Good morning. Good morning.
While Ferenc sorts out his technical issues, I will say good morning to you all and welcome you to the third session of the resuscitation competition. My name is Robin Davis. I'm an advanced clinical practitioner from Birmingham in the UK. I'm joined by my co-chairs, Lucas Fansel Nisacek and Ferenc Sari. I'm going to ask Ferenc to continue by introducing the session. Ferenc, have you managed to
Let's
hope
I have.
Excellent.
Okay. Good morning, ladies and gentlemen. Excuse me for this technical mishap. It does happen. Welcome to the next session of the competition searching for the best demonstration video. My name is Ferenc Sari. I work in Skellefteå Hospital in northern Sweden, and I'm going to work with two colleagues, my co-chairs, Mr. Robin Davis from Birmingham, the UK, and Lucas Fansel Nisacek from beautiful Graz in Austria. The traditional resuscitation competition had to be reformatted so that we could adjust it to the virtual congress. And we asked the participating teams to record the perfect demonstration video. Yesterday, you could see the videos regarding neonatal and pediatric advanced life support. Today, we are going to see some adult scenarios. 5 countries entered the competition in alphabetical order. They are Austria, Finland, Portugal, Turkey, and the United Kingdom. All videos are available in their full extent at the Congress website, so please have a look at them. At this moment, I would like to hand it over to Lucas and ask him to describe the process itself. Thank you, Lucas.
Thank you very much, Ferenc. Virtual competition is quite unusual, so we have been thinking of how such a competition can be rated, and there has been a call to all countries to send in videos for the 3 formats that we have here. So yesterday the pets and the neonates, and today the adults. These videos were then afterwards reviewed by the Science and Education Committee. So that is also why Ileana and Carsten joined us here. And they've already selected some scenes which we will discuss right here in this session. So the Science and Education Committee will afterwards also rate the videos, and this rating will then be combined with the ratings of all the national resuscitation councils. So it will be a mark combined of the SECs and the NRCs, presented at the closing session of this Congress. Additionally, and this is what I want to ask everybody to participate in, is we're gonna have a poll running throughout this whole session where you can participate, and Ileana and Carsten will guide you through the different parts of the videos, and you can constantly adapt your voting. So if you voted once for a country, you can also change that afterwards if you think after this part this is the better video anyhow. So please participate here. We are curious also to see your opinion, and of course we're gonna have the Q&A open here, so don't hesitate to share your questions with us, and we will pick them up and discuss it with the experts here. Yeah, so at this point I want to hand over to Robin to introduce our judges.
Thank you, Lucas. It gives me great pleasure to introduce good friends and esteemed colleagues, Ileana Lulic and Carsten Lott, both of whom are from the ALS Scientific and Education Committees, esteemed experts in this field, and who better qualified to discuss the content of these the excellent videos that have been submitted. Thank you both.
Okay, so good morning, everybody. It's a pleasure being here and joining that session. First of all, I need to say that we have been able to find 5 excellent videos on ALS scenario that has been pre-given, and that is really hard to come to a decision, looking at that 5 expert videos to find out the best of the best. This is why we decided not only to go for 2 full-length videos in that session. We extracted the major bits and pieces out of the 5 videos, put them together under different headings. And this is what we're going to show you within the next, let's say, 50 minutes. We comment on that, but we are more than happy to have your comments via the chat function on that website as well, and your questions for sure, to, in the end, come to a decision what is the best team in that competition. Iliana, anything you want to add?
Nothing at this point.
Fine, so can we please start with video number 1? This is going to show you the briefing, and we only took 1 team for that because this was comparable in all teams. So video number 1, please. It had the best music in the beginning.
Can I give you the scenario for today's case? Yes? Well, you will have Mr. Chandler. He's 35 years old. Chandler's sister called an ambulance because he appeared to be deteriorating rapidly. She was very concerned. He has no significant medical history, but 3 days ago, he was diagnosed with community-acquired pneumonia by his general practitioner. He's being managed with oral antibiotics, and he's arriving at the emergency room, okay? He's coming with the EMS team, and the drive was 4 minutes long. Okay, any doubts about this case, about the scenario?
Is he a COVID-19 negative patient?
Yes, he's negative for COVID-19, yes.
Okay.
Okay, so thanks for that first bit. Now you got the story of the patient. This is what all the teams have to solve within the time frame given. On the other hand, it clearly shows 2 problems in understanding of the whole scenario we had when looking at the videos. If you look at the videos, you will find there are 4 videos that are taking part in the pre-hospital setting, and 1, and this is the one you've seen a second ago, is taking part in the in-hospital setting. And most of the other teams transferred the patient into a COVID situation, so they followed our COVID guidelines. This team managed to kind of take care of the patient in a non-COVID setting. So this is what we need to take into account when looking at the videos and when coming to a decision. Okay, so let's get right into that. Next very important step is when you start structuring your teams, how to structure your team and how to allocate tasks. So this would be video number 2, else, please.
Okay, guys, so patient's name is Chandler, 35 years old, male. He deteriorates quickly. As we know of a respiratory infection, we are going to don our COVID-19 level 3 PPE. Let's do a roll calling. Leo, I want you on the airway.
Airway.
Kati, in the case of CPR, you will be responsible for the chest compressions.
Chest compressions.
Dominic, defib. Defib. Flo, you're going to take care of the sister and do a thorough ample.
I will take care of the sister.
Okay, guys, do you have any questions or suggestions? Leo?
In regard of the COVID-19 pandemic, we should try to avoid all aerosol generating procedures, which means go for if we have to go for back valve ventilation, go for a 2-person technique to avoid leakage, and otherwise go for quick intubation with video laryngoscope.
Thank you, Leo. Kati?
Since we know of a recent infection and a rapid deterioration, we should consider sepsis in our differentials.
Good call. Dominic?
When we're checking for any signs of life, we check the breathing from a safe distance. Additionally, we can feel a pulse.
Flo?
No suggestions.
Okay, guys, let's go.
Hello, my team. We have a good scenario. The patient has a respiratory symptoms, maybe due to COVID-19 infection. We should share the roles, our roles. Nesrin and Nurcan, please, you do the chest compressions. Pınar, you can you use the defibrillator, and please administer the intravenous drugs. And Shule, you do the hearing in, please.
Hi team, I'm Pat. We all know each other, don't we? I'm team leader today. Dave, just remind me, what are your skills? What are you happy to do?
I'm an ALS provider and I'm working on the anaesthetic side today.
So you take care of airway. You happy with that, Beth?
Again, ALS provider, I'm happy to do drugs or defib or chest compressions.
Okay, Vicky?
ALS provider as well, I'm happy to do defib, drugs and chest compressions.
Okay, so we've heard the brief. We've got a 35-year-old male who's unwell from a respiratory point of view. So when he comes in, we'll do an A2E assessment. In the current climate, we'll assume he's COVID positive, so we need to go and get ourselves donned into our FFP3 gear. I'll start the initial assessment, Vicky, if you'll be my helper. And Beth, if we need additional support, would you come in?
Yeah, sure.
Obviously, if we need any advanced airway stuff, we'll call on you to come and help Dave.
You can do the team allocation now.
Okay, so team allocation. Consta, you take the airway, and Mayu, you take B, breathing, and Jenny, you take C, compressions, and Gina, you take D, defib. Okay?
Before he arrives, staff, please, when he arrives, can you monitor the patient? Are you comfortable? Yes. Okay. So João, I know you are comfortable with managing the airway. Is that okay with you? Okay. Sure. Mariana and Anna, if the patient is on cardiac arrest, I will ask you to start compressions. Okay. Otherwise, can you please get me an IV line as soon as possible?
Yeah, of course.
Okay. Yes.
So. Okay, team. Mr. Chandler has just arrived in the emergency room.
So, fine. Now you have been able to see all the different task allocations for our 5 teams. So the main difference I've seen was that the UK team started introducing themselves before they allocated the roles. Otherwise, this was clear communication for all the teams. It was a closed loop communication. So we had the feedback from every responder to the sender and giving them an idea about the task they have taken over. What I really liked in the Austrian team was that they had a second round, where everybody has been able to comment on his specific role and give some input to the team leader. What's your thought, Ileana?
I think, in my opinion, this task allocation phase was really good in setting out the mood for every team that showed us demonstrations, in building up comfort and trust to each other. I agree. What I liked in the Austrian team is that they incorporated this task allocation information received in the briefing, giving everybody in the field of their expertise to give additional input while allocating the tasks and roles.
Okay, so one general comment to the public that is looking at that session. So you can get your comments in, we can read them online, and we are happy to repeat them for all and to discuss them if you have any specific comment on the video sessions we are going to show you. So to conclude that task allocation part, Ileana, they all did very well on that. We had the UK team that had introduction before allocating tasks, and we had the Austrian team that kind of had the second round in discussing the allocated tasks.
Great.
Happy to go on to the next video. So now we're going to go for the initial assessment, and for the sake of time,
Chandler,
one
okay?
letter for each
Okay?
team.
No response.
No response. Let's carry him on the floor. 1, 2, 3. So he is unconscious. Is his airway open?
This is compromised. He is gargling and snoring.
Okay, should I please insert the airway and aspirate the secretions, please? And give a oxygen with a mask at 10 liters per minute.
Okay, of course.
And please cover his face.
Mayu, please listen to her chest and do percussion. Gina, please attach SPO 2 meter and count respiratory rate.
Okay.
Good air entry, bilateral, crackling, breathing sounds, but bilateral equally.
Okay.
Resonant, resonant.
Resonant. Is our SPO 2 meter showing anything?
Shows pulse signal.
For signal, we will still continue with O2 treatment with mask.
Okay. Is it symmetric?
Not really. You can hear better at your right.
Okay, you can hear better. Right. Okay. So for oxygen, please, Mariana, can you take an additional blood gas? Okay.
I put EV line and I have blood samples.
Okay. Thank you very much.
Philippe, last and this is here.
Okay. So he is hypoxic, normal sodium and potassium. Okay. Thank you, Anna. Please start. Do we have a blood pressure?
It's unrecordable.
Okay, so please start on fluids. Anna, please. Okay, one more.
Line established? Yes,
Okay.
140 BPM.
Okay, how is the pulse?
It's a rapid pulse.
Okay.
It's not a very strong one.
Okay. We have fluids. Okay.
Yes.
Yes.
They are
Okay.
entering.
How is the skin? The refill time?
5 seconds.
Okay, he's in shock. Okay, we're going to D.
Key on acting, and I'm just going to have a check of pupils. Excuse me, sir, just give a short look into your eyes. Okay, so bilaterally equally reacting pupils, they're about 5 millimetres in diameter. And he's U on pain, and we need to see what that blood sugar is. And we said we heard there was no other history from this chap, was there? He's 35 years old, previously fit and well, and has had this 3-day history of a cough.
Okay, Kati, let's examine E together. Please fully undress the patient and check for signs of trauma or skin abnormalities.
Checking the skin.
Blood glucose is 9 millimole per liter.
So Dominic, please measure the temperature of the patient. Temperature. The glucose was slightly elevated.
So Bernhard, I've got the information from the sister. Chandler has had a cough, trouble breathing and a fever for 4 days now. He's seen his GP. His GP diagnosed him with community-acquired pneumonia and prescribed him oral antibiotics. No known allergies, no past medical histories. There are signs and symptoms for a possible COVID-19 infection.
Thank you, Flo.
Bernhard, on the examination of the whole body, I couldn't find any signs of trauma or any skin abnormalities. There are no petechiae and no puncture wounds.
Temperature was down.
Was 39 degrees.
Okay, guys, let's do a team update. All eyes on me.
Okay. So in this stream of ABCD approach, in my opinion, we could see two general practices. In one, the team leader was hands off, meaning standing behind a side of a patient's feet, having an overview of a patient. I believe that was in Austria and Finland example. And then UK people kind of stand up in between with a little bit hands off and then hands off the patient. while Turkey and Portugal team leaders had their hands on the patient during the ABCD approach. In my opinion, the approach was structured. They covered most of the important aspects of clinical assessment. The communication was very well, closed loop, clear, having in mind they are wearing this PPE level 3. I think we have to give them a credit for really a good communication skills. So any opinion from your side, Karsten?
Yeah, sure. So I fully share that. And in the meantime, we received a comment, that the PPE is not the correct one for airborne precaution. I think this is something we experience, all of us experience at the moment. So we are short of the equipment for the management of our patients. So for simulation purposes, we need to take whatever we get. So when I run my advanced life support courses here in my course center in Mainz, I also simulate the full protective equipment, but I do not use the full protective equipment because we're waiting of numbers of patients in the intensive care setting to increase, and we do not want to waste that very valuable equipment for that. Okay, so on the other hand, this is something we still need to discuss. You described that very well. The difference between who does the initial assessment of the patient. Is it the team leader, or is this done by the team on kind of managed by the team leader? I know both approaches. I know, for example, from the UK, Robin, correct me if I'm wrong with that, but it's your standard in your courses that the team leader needs to do the initial assessment.
That's correct.
But we actively teach in. Sorry, Robin.
That's correct. Yes. It's part of their assessment right at the very end that they perform an ABCDE assessment. So during scenario practice and during the demonstration, we show them that process, so they're familiar with the assessment process at the end.
So this is what some teams have taken on board. We teach that totally different in the meantime, because we feel this is a process that needs to be done in a simultaneous way. So we delegate the different roads, looking at A, B, and C, and then we receive the results and give them a feedback in that closed loop communication, as Ilyana mentioned earlier on, and then we provide them with new tasks. So this is kind of taken from the trauma setting, where we started doing that way, doing the primary survey in a simultaneous way. This is what's transferred. So I feel both methods are valuable, and they have been pretty well done from all the teams. I have seen a full assessment of the patient in all 5 videos, and I have seen adequate management strategies adapted to the findings they had in that initial assessment of the patient. Okay, and Uwe just gave us a very valuable comment. He wants to know where the teams are from. I thought about adding flags to the videos, but I didn't manage to do so yesterday. Apologies for that. Okay, so for the next video, I'm going to give you a short comment where the team is from when the video is showing up. So now we're looking at the cardiac arrest assessment.
There we go. Oh, so it's going to change the monitor, guys. Hold on a minute.
In UK.
Hello? Can you hear me? No response to pain now. Again, 1, 2, 3, 4. Can you pull the emergency buzzer? Yes. Gone into cardiac arrest. Okay, thank you. Right, you can start chest compression, please.
Deteriorating. Leo, check for breathing. Kati, fingers
yeah.
on the pulse.
In position to feel the pulse.
No pulse. Patient is gasping. Kati,
He is getting worse. Chandler,
This is Turkey.
No response. Okay, any pulse?
No pulse.
No pulse. Okay, it's a pulseless electrical activity. Nurcan, please start compressions, and Pınar, please give a 1 milligram adrenaline.
Can I see any breathing effort?
Finland.
Not rising.
Can I feel the pulse.
There's no pulse.
Patient is in cardiac arrest. Let's start CPR. Can we start compressions?
How is the temperature?
And this is Portugal.
Normal temperature. Okay. So, Mr. Chandler,
You can hear now Mr. Chandler gasping.
gasping. Okay, Mr. Chandler, do you hear me?
Not responding.
Okay. 2, 3, 4, 5.
You have no pulse.
Okay, cardiac arrest. Start
Yeah,
compressions.
okay.
We have an
Okay, so this has been assessment of the patient when starting in cardiac arrest. Yeah, and this was an interesting bit in my opinion. What we have seen are different times, different kind of no-flow times until chest compression started. We had some teams where it took somewhat longer, and we had some teams that have been very fast on that. Yes, but what I noticed is that we had two teams that started counting to 10, despite the fact that the patient was gasping. So this seems to be still in mind, that we need to count to 10 before we take any action. But this has been corrected by the guidelines already in 2015, where we said there's no need to count to 10 as soon as we're sure that this patient is in cardiac arrest, and gasping is a clear sign of cardiac arrest. So this is what I would like to have to see, that they start on chest compressions right away. The Turkish team started doing a rhythm analysis before doing chest compressions in patients, so they even lost some more time before they started them on chest compressions. I think this is a pretty critical time. All teams took long to start chest compressions in the patient getting into cardiac arrest, but there has been differences in that timing. Ileana?
I agree with you. I think you picked up the most important aspects of this cardiac arrest scenario. Especially in these COVID times, it's quite difficult to assess whether somebody is in cardiac arrest or not, which was clearly visible throughout this video. And they have shown different approaches, and there's always a debate whether to feel the pulse or how to approach this. But I couldn't agree more with you.
But on the pulse check, I think this is not different in COVID times. So we're talking about professional teams. And when we're talking about professional teams, we expect them to be able to find the pulse, and this is what we still recommend. So they should try to find the pulse. This is clear, but they shouldn't count to 10. As soon as they notice this patient is in cardiac arrest, they need to start chest compressions right away and not do anything else. So I wouldn't even look at the monitor.
True, agree.
Okay, so no comments from the public on that. That's fine. So the next video, please. This is about chest compressions.
We are going for an intubation with an egg size 4, tube size 8.
Egg size 4, tube size 8, yeah.
Okay, continuous chest compression starting. Are we ready?
Ready. So, Kati, feedback on your chest compressions. Good depth. Good rate.
Patient is in a PEA. Tina, please take 1 milligram of resuscitation adrenaline and give it to patient with bolus, IV. And yes, Consta, please proceed with early intubation when possible and
Okay. We have a non-shockable rhythm. Okay. So Gustavo, please give me. You can say me when we have 2 minutes.
Yes,
okay.
Of course.
And prepare 1 milligram of adrenaline and administer 1 milligram.
Okay. 1 milligram of adrenaline is entering.
So this was a chest compressions setup. The thing is that throughout the whole videos of all 5 teams, overall impression is that they really tried their best in performing high quality CPR, meaning good chest compressions with minimal interruptions, which might not be seen here. The one thing I really enjoyed was the prompts, the use of quality prompts by Finnish and Austrian team, and as well as accompanied by Austrian team leader reassurance and feedback, verbal feedback on the way how chest compressions are going. As well, some nice examples of dynamic approach in which you didn't have any stop in airway management, advanced airway management while doing the chest compression. So no interruptions whatsoever. So these were some nice examples from my side.
Okay, thanks, Iliana. Yes, this is what I noticed as well. So we have seen excellent chest compressions throughout the whole resuscitation from all teams. What I missed is feedback devices. So we had that kind of indirect feedback from the Austrian and from the Finnish team, I think. This is where you have seen the curves, and you had feedback given, and yeah, the Turkish team had it as well. And the Austrian team provided direct feedback by the team leader. This is what I really loved. No doubt about that. So this is what I want to see under the circumstances. Nevertheless, we should encourage the use of feedback devices throughout our training programs and in real life as well. To evaluate the chest compressions that you find in the video. Everybody that has or who has ever done a video in management of cardiac arrest will find out that this is pretty complicated to display that, to see that on the screen in a correct way. So chest compressions always look something fancy if you produce them for some kind of video. I disagree with you, Iliana, on the section with the airway management in the Austrian team, because they kind of feel they work under COVID conditions. So video laryngoscopy is great. This is what we recommend. This is what our guidelines say. But as you produce a lot of airborne particles during that procedure, we recommend to stop chest compressions under the COVID conditions for that situation. So they are trained. We trained everybody for a long time, not to stop, not to pause chest compressions for airway management, and we had to step back under the COVID conditions. Nevertheless, safety of our rescuers is for me first priority. So for the time being, and as long as we have to deal with this pandemic, I would ask everybody not to provide chest compressions as long as we do airway management in these patients. We got 2 questions in the meantime for earlier sections we have seen, and I think one of them is pretty important. And this is about the passive leg raising. We have seen, at least in the Finnish team, the question is if this is recommended or not. So we do not have a general recommendation for passive leg raising, but it does no harm. And especially in that situation where the patient might be a septic patient with distributional shock event, it might really be helpful to raise the legs to get some more volume into the central circulation. So I feel this is a positive point in the whole thing. Okay, so there is nothing else coming in, then let's go to the part I have been most interested in, and this is defibrillation. Next video, please.
Dominic, so the next rhythm check is you. Dominic, I want you to take over for Kati. I take over for Kati. Please turn the monitor so I can see it, Dominic. Leo, fingers on the pulse. Double check the rhythm with me.
In position to check the pulse.
Rhythm check. Kati, stop. Dominic, start.
No pulse, Bernhard.
That's a V-fit, a shockable rhythm. Kati, please apply safe shock using 200 joules.
Applying safe shock using 200 joules. Loading to 200 joules. Every one of the patients. Dominic, stop.
Clear.
Shock applied. Resuming chest compressions, Bernhard and 3.
Thank you, Kati. Dominic, feedback on your...
Tina, please tell me when we have set.
Actually, your 2-minute interval is up within 10 seconds.
Within 10 seconds. Okay, Consta, please place your finger on carotid artery, and Mayu and Jenny be prepared to switch on my count. 3, 2, 1, stop. Continue. There is VF shockable. Sheena, please perform safety defibrillation with 150 joules. Safety defibrillation 150 joules. Exactly. Charge, don't shock. Clear, shock. Continue. Okay, first shock event, so team, we are in shock.
Over. Okay, Nurcan stops the compressions. I will check the rhythm of its ventricular fibrillation. Nesrin, please hand over the compressions, and Pınar, please prepare the defibrillation.
Okay. Everybody stand clear. I will start with 150 joules. I am charging. Please take the oxygen away. Nesrin, continue compressions. Nesrin, stop the compressions. Everyone stand clear.
Nesrin, continue the compressions.
2 minutes are up. Okay, we're coming up to 2 minutes. So when we stop compression, if there's a rhythm compatible with the line, then could you check the carotid head, could you check the femoral? We're going to stop CPR now to check the rhythm. Got the chest, please. Okay, that looks quite disorganised, doesn't it? Looks like he's gone into VF. Back onto the chest there. Vicky, I'll hand over to you for defibrillation. Okay. The gauge we have oxygen well. Everybody else clear, back carry on with compression. I'm charging 200. Everybody else clear, back carry on compression. Everybody's there, breathing down. Everybody's clear, now. Back on the chest, please.
Is it better now than title?
It's now 11.
Okay. The 2 minutes you change with Maria because she might be exhausted. So cardiac arrest on Chandler with no previous medical history. We'll think about the reversible causes. Hypoxic, obviously. Okay, so but he's intubated now.
30 seconds.
Okay.
His crown is strong.
Hypovolemia. We started on fluids. It's an hypothesis because I think he might be in shock.
Yes, I think shock.
Disturbance in the hydrolytes, I don't think so. Sodium and potassium were normal. And hypothermia, temperature was normal. Okay,
10
so
seconds.
cardiac tamponade was no clinical of that.
5,
Maybe
4, 3, 2, 1.
No. Okay, let's stop.
2 minutes.
We have a shockable rhythm, ventricular fibrillation. Please, Gustavo, get ready to shock.
Okay, everyone stand clear. Stand clear.
Okay.
Stand clear. Clear. Shocking. Restart.
Okay, restart compressions. Gustavo, please give me the
So this was defibrillation. I think this is pretty important. I've been told to be overall positive in my feedback, but defibrillation was something that is difficult. Let's word it that way. Yeah. So, I love the way the Portuguese team does it. The Portuguese team has all the aspects I want to see in that defibrillation. They have a planning phase. So there's a clear command 30 seconds before rhythm analysis is meant to take place. Then they start reassigning roads. They use their planning phase to be able to keep the no-flow times as short as possible. Then they have a very focused rhythm recognition. They do exactly what I want them to do. So they look at the monitor for, it hasn't been more than 2 seconds. And this is what we want to have, to kind of take a photo of the screen, and then process that while chest compressions are going on. That's the way to do it. We have seen other teams that start discussing and evaluating the rhythm while nobody's on the chest, and we have extensive low flow or no flow times. This is where we kill our patients in real life. This is something that should not happen. Then decision is made to defibrillate the patient, and they do a safe and focused defibrillation. Now, what I do not understand, and this is what most teams showed, except the Finnish team, they disconnected the bag from the advanced airway they had placed in the meantime. So we clearly say there is no need to disconnect the ventilator or the bag in case the airway is managed with an advanced airway. On the other hand, looking at the Finnish team, they did not even disconnect the bag. They even kept the one managing the airway connected to the bag. So it was a somewhat unsafe defibrillation they provided. Liana, what are your thoughts?
Yeah, I would prefer more upfront planning with the team prior to defibrillation to be implemented in all cases. That would be my preference. In order to minimize pre and post shock phases, as well as I'm not sure whether this situation where actually the Finnish team performed defibrillation was safe. However, it was addressed later on during the debriefing, not seen here. They mentioned something about being cornered and having a little space, but again, I think safety is our priority. And I mean, you cannot afford, because of unsafe defibrillation, to have another possible problem throughout the extensive measure you're performing during cardiac arrest. So that would be my view.
Yeah, but nevertheless, this is something we all should take on board for structure of our future education programs. We really need to teach to keep the no-flow time for rhythm recognition and defibrillation much shorter. So the guidelines say this should be below 5 seconds. I didn't measure times, but not all teams managed to get that below 5 seconds.
Here, not all, but yeah, in general, yeah.
Yeah. Okay, so there are no comments coming in from our audience. So next one is reversible causes, and this is where we picked the tension pneumothorax. That was part of the scenario and management of that. Can you please have the next video, else?
That's a PA, confirming PA 100. Okay, so Dominic, apply 1 milligram of adrenaline and flush it in. 1 milligram of adrenaline.
Bernhard, we seem to have used an excessive amount of pressure to ventilate the patient. I'm thinking that we should go for quick intubation and search for the underlying cause of this.
Okay, Leo, please use a video laryngoscope. Dominic is going to assist you. Adrenaline applied, I will assist you.
Okay, Dominic, we are going for an intubation with a leg size 4, tube size 8.
Leg size 4, tube size 8, yeah.
Okay, continuous chest compressions, Kati. Are we ready?
So, Kati, feedback on your chest compressions. Good depth, good rate, good recoil. Keep it up, Kati. Good job.
Okay. Intubation under the visualization of the cord.
Tube is blocked.
Tube is blocked. Ventilation for my command.
I'm ready.
Puppy stop. Stomach. Left. Right. Okay. Fix the tube, please.
Fixing the ventilated only on the left side.
We have an EPCO2 of 12. The tube is placed correctly. Since there's absent breath sounds on the right side, I'm thinking the patient has a tension pneumothorax. I'm recommending a needle decompression.
Okay, Leo. Dominic, please perform a needle decompression on the right side.
Needle D on the right side. Needle D down. About ear leakage. This confirms our diagnosis can happen.
Thank you, Dominic. So the next rhythm check is due.
The possible cause of cardiac arrest seems to be hypoxia. Let's focus on the cause of hypoxia now. This is over. Listen, stops the compressions. I will check rhythm. Oh, organized rhythm is present. Does he have a pulse?
Yes.
Okay. Okay. The heart rate is 120 per minute. What about the oxygen saturation?
It is 92%.
92%. Okay. Any lump sounds, abnormal lump sounds?
There is no sound in the right thorax.
Okay. Should I please ventilate the patient and we prepare the needle thoracostomy for tension pneumothorax. What about the blood pressure?
74/38.
Okay. How about the consciousness?
GCS is 3 now.
3. Okay. Can I please continue the
Of
fluids
course.
and please start the inotropic support treatment? Yes, it's pneumothorax. Oh yes, that will provide us some time till hospital. And we have to call for a thoracic surgeon for tube insertion. Now we need to transfer the patient safely.
The shot inside the algorithm. We've just given 1 milligram of adrenaline.
Okay again.
So we'll hang fire on the blood at the moment. But we might need to get amiodarone ready if we remain in the shot order. But we've got. So we start stretching the T's. Pops in the nose. Thrombosis in a 35-year-old. He checked his car, so there's no evidence of DVT or anything like that. Cardiac tamponade is registered trauma, and intentionally in the thorax stage, he said he was very easy.
Well, yes, it's going to look a bit more difficult to ventilate now.
Getting more people to ventilate. The next round, can we have a little look at the chest rise, please? Okay, so there doesn't look like there's any chest rise on the right.
No.
Dave, what's the position of the trachea?
He's actually deviated towards the left.
Deviated to the left. Okay, so we've got reduced airway to the side, a trachea that's deviated to the left. Could this be a tension in the thorax?
I think so, yeah.
Okay, so if we can just have a little listen to the chest on next ventilations. No. Artery. No air in the mouth. Okay.
No air entry.
Dave, are you happy to do a needle decompression if we get tension in the thorax?
Yep.
Okay, so we're going to needle in, see if we've got a hiss of air, and we know that we're dealing with a tension in the thorax now with compressions. You might want to pause very briefly as the needle goes in.
The second. Okay, second intercostal space, mid-clavicular line.
Good, good, that sounds hopeful. Okay, so those will transcribe outside. Can you please get someone to set up?
Patient is now intubated, but Consta tells you that impossible to ventilate now. So there's really hard resistance, and you can also see a tracheal midline shift to the right side.
Okay, Jenny, please auscultate the lungs. Start from left side. We might have possible treatable cause, tension pneumo. Ask Mayo to stop.
No breathing sounds on left side.
Okay, Mayo, continue. Jenny, please perform needle thoracocentesis on left side. Needle thoracocentesis on left side.
So air coming up, high pressure.
Consta, how's the ventilation now?
No, it's easy to ventilate now.
Very high pressure inflating the patient, and I can confirm the tube is correctly placed.
Okay, so high pressure on ventilation and an asymmetric auscultation even after cardiac arrest. So I'm thinking it might be tension pneumothorax.
Exactly.
Do you agree, team?
Yeah.
Yes. Okay, so Mariana, are you comfortable with inserting the needle? Okay,
Yes.
so let's decompress the pneumothorax.
I think I can confirm the diagnosis.
Yes, okay,
Yes.
so we have a high tension pneumothorax. Now we have decompressed. So Mariana, if
1 minute is much easier to ventilate.
Okay, so Mariana, are you comfortable with inserting a chest tube?
Yes.
Okay,
1 minute gone, Philippa.
Well, in this set we saw one of the four T's, so tension pneumothorax. I believe, if I'm correct, only Turkish team had the development of tension pneumothorax after OSC. Interestingly, each and every team decided to go with a needle decompression, which is for me quite interesting. I'm a bit biased because I personally would go for thoracostomy, having in mind patient is already ventilated in advanced manner, and you're surely going to anticipating that you're going to do the ventilations later on, mechanical, which just going to complicate your life. Having the thoracostomy done would, I think, bring you on the more safer side, as well as but what I like, I think Portuguese team, and if I want one more playing up front, that they might need a thoracostomy in future. And I think that's from my side what I have noticed throughout this set of. One more thing, I'm not sure whether you could actually do needle decompression while ongoing chest compressions, and putting a 14 gauge needle from personal experience. 3 times I've done it, it never worked. It never reached the space, and we also noticed the different sides of decompression. So any thoughts from your side, Karsten?
Yeah, so fully agree. Yeah, so this is a different between medical cases and trauma cases. In trauma cases, most of us would go for the thoracostomy right away. This is what we recommend for medical cases as well. If you have a tension pneumothorax in a cardiac arrest patient under those circumstances. Overall, they all managed the reversible causes. They all found out about the tension pneumothorax, and most of the teams, it took some time to handle the tension pneumothorax. What I thought was interesting is that most of them tended to intubate the patient first before going for management of the tension pneumothorax. This would, in my opinion, eventually be the place for the needle thoracentesis. If you want to go for an intubation, then put the needle in first, and then intubate the patient, and then go for the thoracostomy. But nevertheless, they all managed to do it. They all found it, and they all took an adequate action for that. And else, now this is for you. In sake of time, we are gonna skip video number 8 and would go for video number 9, non-technical skills, right away, if that's fine with you. So number 9 now, please.
team. My name is Filipa. I am team leader. We are going to receive Mr. Chandler, who is a 35-year-old male with an acquired pneumonia that is being brought to the emergency room for us to evaluate. Okay? Any questions? Okay, so I'll distribute the tasks before he arrives. Staff, please, when he arrives, can you monitor the patient?
Yes, no
Are you
problem.
comfortable?
Yes,
Okay. So João, I know you are comfortable with managing the airway.
Yeah.
Is that okay with you?
Yeah, sure.
Okay. Mariana and Anna, if the patient is on cardiac arrest, I will ask you to start compressions.
Okay.
Otherwise, can you please get me an IV line as soon as possible?
Yeah, of course.
Okay. So,
Okay, team. Mr. Chandler.
He's compromised. He's gargling and snoring.
Okay, should I please insert the airway and aspirate the secretions, please, and give a oxygen with a mask at 10 liters per minute.
Okay, good.
And please cover his face.
Know that that patient is not doing any respiratory efforts anymore, and he's not reacting anymore.
Okay, Jenny, excuse me. Chandler, are you awake?
He doesn't respond.
Can I see any breathing effort?
Chest is not rising.
Can I feel the pulse?
There's no pulse.
Patient is in cardiac arrest. Let's start CPR. Jenny, start compressions. Tina, please give feed backup device to Jenny and attach defib.
Yes.
Tell me when defib is ready. Compressions, ventilations, 30 to 2.
Defib is ready.
Defib ready, so we will perform initial rhythm check on this. So we will perform initial rhythm check on the microphone. First, please place your finger on carotid pulse. 3, 2, 1. Stop. Pulse.
9 degrees. Okay guys, let's do a team update. All eyes on me. We have a critical patient with a severe B and C problem. Our current working diagnosis is sepsis. Plan of action will be to add more fluids and apply a norepi infusion. Do you guys have any suggestions? Dominic? Leo?
No suggestions.
Kati?
And in ED today, we've just had a patient come into the department who had a cardiac arrest, so I'm hoping to hand over to someone that could come and admit him to the unit.
Yeah, I'm the intensivist on call.
Fantastic. Hi there. So we have a patient called Chandler. He's 35 years old and came in with a history of 3 days of community-acquired pneumonia, not responding to oral antibiotics, and became acutely unwell this morning. He came in short of breath and without recordable saturations. When he arrived, he was still breathing, but he was working quite hard. Respiratory rate was very high and shallow with lots of crackles. So he looked overtly septic, so we started the sepsis 6 on him. And unfortunately, within a few minutes, he went into PEA arrest. So we had a 2-minute loop of CPR, followed by a shock for VF that he went into, and we just had return of spontaneous circulation. So the main concerns at the moment are his GCS is very low, he's got an IgA in situ and a chest full of secretions. He had a tension pneumothorax as part of this whole journey, so he now has a needle decompression, which we're just about to convert into a formal chest drain. And he still remains hypotensive despite fluid resuscitation and adrenaline during the cardiac arrest. So he needs critical care input if you can come down and support us.
That's absolutely fine. I'll be right down.
Thank you very much. We'll carry on managing until you arrive. Thank you. Bye. Right to you, critical care.
Thank you. We'll end the scenario there. Well done.
Liana, may I ask you to start on that as you did it?
Okay, this final video was, from my point of view, very well presentation of non-technical skills in terms of task allocation, teamwork, decision-making, situational awareness from all countries. One nice point was the structured communications presented by the end from the UK team as well as Austrian team. 10 pause, 10 seconds for 10 minutes pause or timeout or stop procedure, call it whatever you want. But so everybody in the team sings from the same hymn sheet, shares the same mental model to be on a safe side. So these are my remarks.
Yeah, same for me. So I really liked the non-technical skills that have been shown in all of the videos. So something that was missing for me, this is what I tried to put in an extra video. This is the one you skipped now. I missed the debriefing. In the end of patient management in all teams. None of them did that. There also at one point of time, we stop now and that's it. I think this would be of additional value, especially if having a focus on our non-technical skills.
Agree. Good point. Yeah.
Okay, so no points on that coming in. So I'm happy to hand over to our chairs. Many thanks for having had the occasion to discuss videos in that way.
Thank you, Carsten.
Thank you both. We'll just hand over quickly to Lucas to perhaps talk about the poll.
Yeah, thank you, Robin. So we have the poll open. So I encourage everybody to use it after we have seen now different aspects of the whole simulations that were coming in. Currently, we do have 74 people active in the poll, and numbers keep increasing, 76 eventually. And we have the Finnish team now in the first place of the public poll with 30 or 40%. And then eventually we have Austria as a runner-up with 25%, and then the Turkish team following UK and Portugal. So yeah, polls, people keep electing, but I think it will stay the same. So Finland is on place 1 here in the poll.
Dear all, it's my turn to take over and say thank you for all the contributing teams, for all my colleagues working on this panel, to my co-chairs, and for the experts from the Scientific and Educational Committee responsible for ALS questions. Also, I would like to give a special thanks to Els, who was helping us as a technical support in the background from the office. The results will be announced at the closing ceremony, which starts at 16:30 this afternoon, Central European time. And now I'm closing this session, asking all the audience to remember to sign out from this session before they enter a new one. So thank you ever so much for joining us. Thank you very much for your help. Goodbye.
Bye.